The opinions and views expressed on this program do not reflect those of the management or staff of Community Media of Staten Island.
Welcome to RUMC Vital Signs. I'm Alex Lutz. On our show, you'll meet the fantastic people who make Richmond University Medical Center thrive. RUMC is an award-winning full-service hospital located right here on Staten Island at 355 Bard Avenue. To learn more about the full array of services provided at RUMC, visit rumcsi.org. Over 200,000 people a year in the United States are diagnosed with a hernia, an often painful bulging in the stomach and abdomen area. Here to discuss this common condition, its causes, and potential complications if left untreated, is board-certified surgeon Dr. Alex Barkan. Dr. Barkan attended medical school at St. George's University School of Medicine, followed by a general surgery residency at Maimonides Medical Center in Brooklyn and Hahnemann University Hospital. He then completed a fellowship in minimally invasive surgery, as well as laparoscopic and robotic surgery at University Medical Center of Princeton. Welcome to the show.
Thank you.
Thanks for coming on. So, in layman's terms, what is a hernia?
So a hernia, if it's like a pocket in your pants.
Okay.
When the pocket is empty, it's just flat. But when you put something in your pocket, it becomes full. So that could be fat from the body, that could be intestines in the body, and that makes the pocket full, and then it becomes an active hernia that the patient sees and feels.
What causes a hernia?
So most hernias are due from surgery, from previous surgery. Patients who had previous surgery have a tendency to get hernias in those sites. There are hernias that are not due to previous surgery, they're due to genetic predispositions such as groin hernias or things that, if they're heavy lifting, they could be a rupture of a muscle that can cause a hernia. There are different pockets in the body where muscles cross and meet in different pockets. So in those spaces, there are spaces between those muscles. Those could be sites of hernias as well. So those are pretty much the sources of hernias.
What are the different kinds of hernias?
So there are groin hernias, there are belly button hernias, there are hernias all along the midline, and there are some hernias called Spigelian hernias that are found lateral to the midline in areas where you would not expect them to be, but they're usually in areas where muscles meet. And in between those areas is where bulges can occur. They could be genetic, they could be congenital, which is patients would be born with them. They can be acquired as well. And so those are pretty much the type of hernias that we have in the abdominal area.
And often when people hear of a hernia, they like you alluded to, it's from lifting something heavy. What kind of a hernia what is that?
So you can get a groin hernia from that. So sometimes when the embryo develops, and particularly the male, the testes start in the abdomen. And as the infant grows, they descend from the abdomen down into the groin and into the scrotum. But they have to get there through an open process, through open areas, because if the lining is closed, there's no way for them to get into the scrotum. That open area, called process vaginalis technically, sometimes doesn't close completely. And these hernias then develop over years in patients. And so that's one source of groin hernias, if the process vaginalis is open. And so if you lift something heavy and you force the area, it'll give way. That's one area. Sometimes there's something called sports hernias, where athletes, because of their movements, lateral movements, particularly soccer players or football players, can cause tearing of the lining of the muscle that inserts into the bone, the pubic bone. And those tears can also be a source of hernias in the groin. And of course, those groin hernias can contain different parts of the body. They can have fat, the body fat, they can have the intestines, and they can have the appendix sitting there, the bladder sitting there. There's different kinds of groin hernias. There's something called direct and indirect. It has to do with the anatomy, but they're fixed in a similar way. And there's also different canals in the body where vessels naturally come through, like the femoral canal. That could be a source of hernia. There could be also hernias in the pelvis, particularly in very thin people who are bedbound, such as nursing home patients can have hernias that are inside the body, inside the pelvic bone areas where normal cavities are for nerves and vessels to pass through. And then, of course, in the abdomen, from previous surgeries, those, because once you cut the lining of the body, it's weak. It's never the original strength, even though it heals. It's never the original strength, and that could be a source of hernias as well.
So outside of heavy lifting or an injury, is hernia something you see in older adults? Children get it? Can have hernias?
So children can be born with hernias. Children can be born where the abdominal wall does not close fully, and they can be born with natural hernias. They can be born with natural groin hernias because that process vaginalis hasn't closed, and so so they can be born with it. They can develop it later in life, and older patients who, with age, gain some weight, maybe don't exercise much. The midline, there's a midline, let's go, the fascia in the midline that separates the two six-pack muscles that we have in the abdomen. That lining stretches. And so patients sometimes get out of bed and they see like a coning in their abdomen, and they say, oh, I have a hernia. And that's not necessarily a hernia. It's a natural process of just aging and stretching of the abdominal wall, but they can also be fixed using surgical techniques as well. In the past, it wasn't fixed because we didn't have the advent of robotics and laparoscopy, but because we do now, we can actually fix these abdominal wall hernias.
I see. Do all hernias present as a bulge?
Yes, they all present as a bulge. Sometimes the hernias could be as an emergency. For example, if you have fat or intestines stuck in the hernia and it can't come out. Sometimes hernias, the patient has a hernia for a long time because the bowel comes in, it comes out, it comes in, and comes out. Or the hernia is very large, and so it can accommodate a large amount of bowel. But hernias that have, for example, small openings and have a large amount of bowel in them, the bowel can't come back. And now as that opening sort of squeezes around the bowel, it decreases its blood supply, and it can be turned into an emergency due to lack of blood supply to the intestines. So those hernias can become emergencies. And the reason to fix a hernia, there are three reasons to fix a hernia. It's if there's pain associated with the hernia, if it's increasing in size, which all hernias do, they never decrease in size, they only increase in size. And the third reason, if it affects the patient's lifestyle. If a patient is a physical laborer, or if the patient does certain things physically, goes to the gym or exercises or gardens, and every time they bend down, they have a pulling, a hurting, and it affects their lifestyle, that's an indication to also fix a hernia.
So it sounds like you can live with the hernia, but the hernia is not going to resolve itself.
Hernias never resolve themselves. They only get bigger, but you can live with a hernia if it's not bothering you, if it's not affecting your lifestyle, and if you think that the size is not increasing tremendously over a short period of time.
So how do you diagnose the type of hernia that it could be?
So the patient presents clinically, usually with pain in a certain area, and you palpate, you inspect the abdomen, you then palpate the abdomen, you ask them to make a muscle, you ask them to bear down to create the tension in the musculature, and you can see a bulge. Oh, they'll tell you, when I get up, doctor, every time I get up, there's a bulge here. When I lay down, it goes away. So that's another way. Or doctor, when I get up out of bed, I have a coning. Or doctor, there's pain in my groin, and then you palpate a hernia. You ask them if it's a male or female, ask them to cough. Both females and males can have groin hernias. It's more common in males because of that whole embryological concept of the testes descending into the scrotum. Females don't have that, and so they have less chances of groin hernias, but they can occur as well.
So if we're talking about weight as the potential to cause a hernia, can pregnancy cause a hernia?
Yes, many women have umbilical hernias, belly button hernias, that they have symptoms from because of the continuous growing of the abdomen and stretching, and then they have to be fixed after surgery. They also get this, what's called diastasis, where there's a loosening of that fascia in the midline, and they can have that coning, or they can have a chronic sort of laxity of the abdomen due to the extent of their pregnancy or how large the baby is. And that can also cause this sort of bulging, a natural, sort of a general bulging of the abdomen that may require surgical repair.
And as a bariatric surgeon, do you find hernias in people that are coming in for possible weight loss surgery?
So hernias can happen in all kinds of patients, weight loss surgery patients. There are also internal hernias, such as hiatal hernias, which is a hernia in the diaphragm, and that can be a hernia of a stomach. Hernia is essentially a general term, like I said, a pocket in your pants.
Right.
If you fill that pocket with something, it becomes a hernia. So it could be internal hernias as well. But patients who are overweight or live with weight, they can have hernias, long-standing hernias, that they might need to be fixed prior or during surgery for weight loss.
And once you diagnose the hernia, how do you treat it?
So again, we speak to the patient. The patient comes to us complaining of this hernia, then we obviously think that the patient has issues that are affecting their lifestyle. So we offer surgery for these hernias. Surgery is the only treatment for hernias. And we offer surgery for these patients. And then the patient decides when it's right for them to perform surgery, or they want to wait, or they want to proceed. It depends on how big it is, what's stuck in it, and how it's affecting them.
And what kind of surgery do you perform? Is it different kind of surgeries, or?
So with the advent of robotic surgery, many of these hernias, or most of these hernias, can be done robotically. And that allows us to work in certain areas with great precision, because due to visualization. The abdomen has different layers. The abdomen has a skin layer from the outside, has an internal fat layer. It has a fascial lining that covers the muscles, and it also has something called the peritoneum. The peritoneum covers the intestinal organs. All those different layers can be used to repair hernias. In the past, hernias were done open. You would have to repair the hernia, place a piece of material, but the reality is, in an open hernia, you can't place a large enough piece of material because you have to be able to secure it, and you don't have the ability to secure it because you can't get to the areas we need to secure it. Robotically, we can actually see the whole abdomen because it's like a dome. We see the whole abdomen, and we're able to place large pieces of mesh, because the secret to hernia repair is a certain amount of mesh covering beyond the hernia. You have to have a certain amount of covering beyond the hernia for it to be sustainable, for it to be not be able to come back. So you have to have a certain, real estate purchase around the area of the area. Robotics allows you to do that. In the past, mesh, which is always used, probably most of the time is used to repair hernias. Mesh used to be placed into the abdominal wall, inside the abdomen. And so what happens is scar tissue can form, which naturally forms in the body. Scar tissue could be fat, could be intestines. That intestines can be chronically stuck to that mesh. And if further surgery is necessary in the future, it becomes a very challenging situation where you have to peel the bowel off the mesh. Sometimes the mesh has to be removed. With the advent of robotics, we're able to go beyond just the abdominal wall. We can go into those different layers of the abdomen, place mesh in all those different layers of the abdomen, preventing the bowel from directly touching the mesh, decreasing risk of adhesion, decreasing risk of fistulas, decreasing the risk of complications from obstruction for later. And so robotics has allowed us to do that. Robotics in inguinal hernia repair, for example, I have patients who have had open repair and also had robotic repair. From one side, they had open in the past and robotics with me. They are sort of their own controls and their own experiments, and they tell you that the difference in pain is significantly better compared to the open repairs, which take 6 to 8 weeks to heal, chronic discomfort, whereas robotically, they're up and about within the same day, but their soreness is more related to just the dissection of the tissues rather than the actual hernia repair. So it's a tremendous benefit to lifestyle, quality of lifestyle.
So when you're going in there surgically to repair the hernia, basically using your analogy of a pocket, you're basically unstuffing the pocket? Is that what you're doing?
Unstuffing the pocket, and you're actually removing that pocket. That pocket usually has the natural lining of the body. That's the pocket. So you're removing that pocket. You're collapsing that space around the pocket. The body naturally scars it down to prevent that pocket from reoccurring again. So you're either closing the space, or you're just taking away the pocket, such as in a groin hernia. In an abdominal wall hernia, you're taking out the pocket and you're repairing the defect, because there is a defect in the lining of the abdominal wall that allows that pocket to form.
And then after hernia surgery, what's the recovery time like? I mean, no robotics cuts down on that, but what is the recovery time? What would you recommend people avoid? What should they do? So
what's interesting is that with the advent of robotics, time to return to normal lifestyle is much shorter than it is with traditional open repairs, because you could imagine an open scar, pain from that, healing from that. It takes time. But with robotics, with little incisions, you prevent further hernias from happening. You're also not, you're placing mesh, which is the material used to cover these holes. Most of the time mesh is used. I mean, it's important to do that. Nowadays we have mesh that is like Velcro, where we place the mesh. We don't have to sew it in. We don't have to stitch it in. We don't have to put clips in it like we did in the past. We don't have to, it just put it in place, and that also adds to the relief after surgery. So essentially, they're dealing with very minimal discomfort. Now, in abdominal wall hernias, we do tell patients that if surgery doesn't hurt, then it's not done correctly. There is going to be some discomfort in the abdominal wall. But with the advent of these new techniques where we can create pockets and just place pieces of mesh without sewing, without clipping, that also the pain will decrease over time because the more and more surgeries like this are done.
And they can basically go back to resuming a normal lifestyle, or someone, like say someone's a construction worker, is there something like, that's something they shouldn't do again, or they basically go back to normal life?
Well, you know, traditionally we talk about 6-8 weeks of no heavy lifting, more than 5 to 10 pounds. You know, no using your legs to lift something rather than your back. You know, sort of staying away from things. With robotics, return to lifestyle can be much quicker. 2 to 3 weeks you can return back to lifestyle. Of course, you know, every situation is different. If you have a large abdominal wall hernia that you just repaired, you don't want that patient going back and doing construction work in 2 weeks. If it's a groin hernia that's just, you know, done, I guess, bread and butter groin hernia, then of course you can return to work quicker. But a large hernia or a recurrent hernia or a more difficult situation, the patient has to use sort of common sense to know that you have to wait several months before you can actually resume heavy lifting, resume some of the things that they may be used to in their daily life.
And as a surgeon, I imagine when you first got into surgery, robotics was not around, right?
Well, yeah, I mean, actually, when I was a resident, robotics started. I started with the era of robotics. Probably 2-3 years into my residency, robotics came into play.
And did when robotics come along, was it like only for certain things and it expanded over time, or was it like introduced to the medical world as for everything?
Yeah, so it started in cardiac surgery.
Okay.
So initially mobilizing the cardiac vessels necessary for, and also the precision, because the vessels that are small and to be able to see them better. So cardiac surgery was the first surgery where the robot was utilized in. And then slowly it evolved into different specialties. Urology became the next specialty to use the robot, and then OBGYN. But general surgeons actually were the last to start using the robot. But today, with the advent of techniques and the surgeon's comfort with robotics, it's become a main staple of surgery in general surgery.
And how long did you have to train on a robotic system before you felt comfortable? And actually, what was the training like to do hernia surgeries?
Yeah. So what's, you know, in residency, although robotics came into play when I was a resident, I didn't start to do robotics about till 2012. And you have to go through different steps. It was learning about the robot. It was then getting proctored by an experienced surgeon. It was doing things on a cadaver, so it's different techniques, and then of course experience. And so at this point, of course, I forgot the last time that when the moment was that I started using it and the moment that I felt comfortable. But I've been using it since 2012 continuously in multiple different kinds of surgery. In terms of the learning curve for the robot, what's interesting is that many surgeons who have not done laparoscopy, old-time surgeons who would just do an open surgery, did not do laparoscopy, got into robotics and became very proficient because they knew the anatomy. And so, it's easier to learn on the robot than it is to learn laparoscopy. And I've worked with surgeons towards the end of their careers who started doing robotics and were able to do hundreds of cases robotically, and then they never did laparoscopy.
And I think for people who are watching the show who are unfamiliar with robotic surgery, I guess they have this vision of the robots doing the work, and you're kind of maybe not even in the room, but that's not the case.
No, it's never the case. The robot is just a tool. It's not the robots that are walking around on TV sets doing their own thing with their own minds. You know, it's a tool. It just allows us to be more precise with work.
And now you're using it primarily for bariatric surgeries, correct, as well?
Yes, we use it for bariatrics, we use it for general. We try to use it as much as we can. We use it for colon surgery, we use it for anything that we can use it on. We try to use the robot.
And is it like a constant state of learning to do it?
It is a constant state of learning because most of the sensations are visual. There's no tactile sensation. Although with a new robot, there is some tactile feedback.
Really?
But most systems are all visual, so your cues are visual. So it's sort of like this intuitive, which is the name of the company actually. It becomes intuitive. Using the robot becomes intuitive. You know how much pressure to apply. You know how much pressure not to apply to the organ or the surrounding tissues. It becomes intuitive. And so, for example, I'll give you when you're tying suture and when you're tying down, how do you know when to stop tying? Because you have no feedback. So you can just rip the thing. Well, you actually look at the depression of the tissues as you do it. So as the knot comes down and the tissue gets depressed, you know that's a not tight enough knot, and you stop. That becomes automatic eventually, but initially you sort of have to follow those cues.
And at any point in a surgery, I guess, if something happens, you may have to stop using the robot.
Yes.
And you're able to do that.
Yes, well, yes, you're able to do that. You know, we're sitting at a screen and we have our heads in the screen. As soon as you get your head out of the screen, everything stops. Like the robot will not function if you're not visually there looking.
It's that sensitive.
It will just stop.
Oh,
yeah,
wow.
you can't do anything if you're not physically looking into that screen.
Wow, that's really sensitive. It's almost like playing a video game. It sounds like there's some
right, and of course, you know, kids these days who are playing video games, they're actually very good at the robotics, very good at these things because they're used to constantly working with their fingers and their hand without looking. So it becomes a very interesting.
And getting back to hernia, do you find there's an age group or demographic that gets hernias more than others, or?
It's not, well, of course, the older patient can have hernias more common than younger patients, but it's also a patient, for example, an athlete who works out all the time can also get a hernia, rip under lining, abdominal wall lining, or physical labor who can get a groin hernia. Now, I do see patients who have long-standing hernias, particularly in their groin, they're large hernias, because patients are afraid of surgery, and so they allow these hernias to grow. And then they present and say, I want this fixed, but they had it for years because they're afraid of surgery. And this, I guess, you know, with the advent of robotics, they don't need to be as afraid because they're small incisions, same-day hernias, same-day repairs, you go home the same day. So that's something that, and patients walk around with these things for many, many years because they're afraid of surgery. And because they don't know that we have minimally invasive techniques now. We don't have to make big cuts. There doesn't have to be a big production. A lot of times. Sometimes it has to be a big production. Sometimes these hernias are very, very large. Simple techniques will not fix them. They require much more expertise. They require much more, a longer period of time. Robotics might not be able to do it because the hernia is so big. So it's not 100%, but it's probably 90% of the time that a robot can be used to fix it.
And we talked about a hernia creates pain and a bulge, but a hernia could lead to serious complications.
Of course, it could lead to emergencies. So the thing is about hernias is when you look at the pocket itself can be large, but the entrance to the pocket can be small. So you can have a large entrance, which may accommodate much more intestines, much more fat, and not prevent squeezing of those intestines, prevent squeezing of the blood supply to the intestines. But if the opening to the hernia pocket is small, and you have a lot of bowel contents in there, it can escape. And that and it sort of becomes a collar around the intestines, squeezing the blood supply, causing a lack of blood supply to the intestines, and causing an emergency situation that requires emergency surgery.
Wow. And we talked about you said infants can get hernias.
Yes.
How would you repair?
Well, you know, again, with infant surgeries, there are small instruments, 3-millimeter instruments that are used for kids as well. Kids is sort of the pediatric surgeon does more of that patient population. We deal with more of the adult, you know, the over, let's say, 15, 18-year-old, and then and above. The pediatric surgeon deals with the infants, deals with the preemies. It takes much more expertise, which they usually have training for.
And you mentioned that you see it a lot in seniors. Is that just because of wear and tear on the body, or they lift something they shouldn't?
It's a combination. It's a combination. I mean, for example, if a patient's large weight, they carry this weight with them for many, many years. Eventually things stretch, eventually things give way. Or you have a very thin patient who has not much musculature, who has a weakness, who maybe lifted something. That could be a source. It could be also, you know, in between. There's a tremendous spectrum of patients that have hernias. And some patients walk around with hernias for many years, afraid to fix them because they're afraid of surgery. They're afraid, and because they just don't know that we offer these small, minimally invasive techniques that are, first of all, less painful, same day, and prevent recurrences.
And how long does the average hernia surgery take?
It depends on the hernia. I mean, a groin hernia, you know, a straightforward groin hernia can take 20 minutes. A long, large abdominal wall hernia that has multiple defects, so sort of like a Swiss cheese defect, that may require an hour or two because you have to be able to dissect the different planes, get into certain planes, fix it, place the mesh, and you know that takes time. That takes time.
Is a hernia usually localized, or you can have hernias in multiple?
You can have hernias in multiple areas. Most of the time it's one hernia, maybe two. But in the midline, if a patient had previous surgery, for example, patients can have multiple hernias. And patients, particularly who had previous surgery, one of the things is doctors are reluctant to go back into their abdomen because of scar tissue. We can actually stay above the abdominal wall lining. We can stay above. We don't have to go into the abdomen. We can stay above the abdominal wall lining and work in that space because of robotics and prevent us from getting into the abdomen, dealing with scar tissue altogether, which can help the patient a lot in terms of complications.
So it sounds like if somebody has or again, you're saying it's a bulge is really kind of the telltale, and that's when they should go to their doctor. And you said surgery is really the only solution for that. But it sounds like between the technology, the advances, that it's really not anything to be worried about. It can be taken care of pretty quickly.
Yes, I mean surgery is surgery. When we talk about not worry, surgery is surgery. Things can happen. Patients have to understand that that things can happen. But of course, we try to take great care for the things not to happen, and that's why. One of the ways to do it is prevent big incisions, big cuts, long surgeries, and that's what robotics helps do.
And just about any kind of hernia that you've talked about today can be treated at RUMC?
Yes.
Great. Thank you for coming on the show. Thanks for all that you do. I'd like to thank Dr. Barkan for coming on to today's show to talk about hernias. If you would like to schedule an appointment with Dr. Barkan, you can call 718-818-4020. Dr. Barkan's office is located at 1161 Victory Boulevard, inside the Dr. Krishni Urs Medical Pavilion. Richmond University Medical Center has cared for Staten Island and the New York City metropolitan area for over 120 years. You can help ensure that care continues by making a financial contribution to the hospital. Donations can be made in your name, the name of a loved one, or to honor a special nurse or doctor at Richmond University Medical Center. To donate, visit our website at rumcsi.org and click on the donate button, which is located at the top of the homepage, or you can call 718-818-2106. That just about does it for this episode of RUMC Vital Signs. Thanks for joining us. I'm Alex Lutz.
Produced through the facilities of Community Media of Staten Island.